Welcome to Mayo Clinic's ECG segment, Making Waves, continuing medical education podcast. Join us for a lively discussion on the latest and greatest in the field of electrocardiography. We'll discuss some of the exciting and innovative work happening at Mayo Clinic and beyond with the most brilliant minds in the space and provide valuable insights that can be directly applied to your practice. Welcome to Mayo Clinic's ECG segment, Making Waves. In this episode, we examine the complex intersection of cancer and atrial fibrillation, two conditions that, when they coexist, present a unique clinical challenge. Our discussion will focus on stroke prevention in this high-risk population, where the decision to anticoagulate must balance its bleeding risk and the cancer-related complications. We'll also look at the overall prognosis with this rhythm disorder. Now, joining us is a cardiac electrophysiologist with deep experience in this space here at Mayo Clinic. He's kind of leading this space and helping us learn about how to manage these patients. We're going to explore the link between that cancer and atrial fibrillation, what makes it difficult around anticoagulating these patients, and then the emerging role of left atrial appendage closure as an alternative strategy. So let me introduce our guest today. Dr. Nicholas Tan is a cardiac electrophysiologist at Mayo Clinic in Rochester, Minnesota. Dr. Tan's journey began with biomedical engineering degree at Johns Hopkins University. He then earned his medical degree and a master's in biomedical investigation from the Cleveland Clinic Lerner College of Medicine. His training continued here with internal medicine residency, cardiology fellowship, and cardiac electrophysiology fellowships at Mayo Clinic in Rochester. More recently, Dr. Tan completed a master's degree in medical device innovation from the University of Minnesota. And he's now continuing to push the boundaries in heart rhythm treatment with research on device-based therapies and in this cancer population group. Dr. Tan, thank you so much for joining us again.
I appreciate it. Thanks a lot.
Now, we keep having you back and we really enjoy. I think this is a special group of patients, and we've talked about radiation therapy in the past, and many should go back and listen to those episodes if they haven't. Now, we know patients can develop rhythm issues, and atrial fibrillation is that common one that comes up. What is that relationship between the two, the cancer and AFib, and how you see it?
I think we are beginning to understand some of the intricacies between atrial fibrillation and cancer. Some common themes that we often see between the two is that they are both associated with a pro-inflammatory state. So patients who have cancer and active cancer at that are oftentimes subject to degrees of inflammation, and that is a breeding ground, if you will, for atrial fibrillation. So that's one aspect. The second is that patients who are treated for their cancer are often using therapies that can be associated with cardiac side effects, atrial fibrillation being one of them. So there can be some direct toxic effects that trigger arrhythmias as a result. Now, the third element is somewhat of a mixed bag in the sense that because we are much more able to treat cancer patients with newer drugs, newer therapies, these patients are living longer. And so they have the propensity to develop atrial fibrillation as they get older, which is, again, something that we will see in the general population. So it's probably a combination of these reasons that leads to atrial fibrillation being something that we not infrequently see in cancer patients, and maybe in patients who are even younger that we typically expect in the general population due to some of these other special factors.
And so you kind of mentioned this pro-inflammatory state in these patients, cancer patients with atrial fibrillation. What makes stroke prevention particularly tricky? And maybe even from the anticoagulation side, are there challenges that you face as a clinician?
There is a classic teaching in medical school called Virchow's triad, and that's where we think about the factors that lead to clot formation. So one of them being increased inflammation, one of them being increased venous stasis, and one of them being in a procoagulatory state. Now, cancer patients have all three risk factors, and that makes them vulnerable to forming clots and developing strokes as a result. Now, on the other end of the spectrum, there are also a patient population who may be at risk for bleeding. So if they receive chemotherapy or bone marrow transplantation, for example, they are subject to anemias, thrombocytopenias, and those patients are very difficult to anticoagulate. So the typical treatments that we would think of using for stroke prevention, warfarin being the classic example, but nowadays using one of the novel anticoagulants, those can be quite challenging to use in this patient population just because they are walking a fine line, if you will, between having a stroke and having a bleed.
It is this fine balance, as you mentioned, the Virchow's triad, and also preventing them and minimizing or avoiding that risk of bleed. And that kind of brings us to this left atrial appendage closure. And this is becoming considered, how do you see this fitting in more of the broader stroke prevention strategy in these patients?
Yeah, so I think this will be a very interesting space to explore in the future. Now, left atrial appendage closure has been around for some time. It has its ups and downs over the past few years, but it's definitely on the rise. Again, in the general population for stroke prevention as an alternative to systemic anticoagulation. We don't have a lot of experience in cancer patients. On our part, we published our own series of patients who underwent percutaneous left atrial appendage closure and tried to compare them in patients with no active cancer. And for what it's worth, we did not see any major increases in complications related to the procedure itself, nor did we see any significant differences in terms of stroke mitigation. So they compared fairly favorably to patients who did not have any active cancer. Having said that, this was a retrospective study, so more information will be needed. Now, we actually wrote up a review article recently regarding this question, and embedded within that review article, we expounded on a case that we saw over the years, a patient receiving left atrial appendage occlusion. And did well initially. He came off anticoagulation afterwards, as we normally would with in most other patients. And then when he returned for a serial transesophageal echocardiogram, we actually saw thrombus form on the other side of the device. And so we had to put him back on anticoagulation. The thrombus went away. We took him off the anticoagulation, and then the thrombus came back. And again, this goes back to what we mentioned earlier, where these patients are just so vulnerable to forming clots that despite this percutaneous treatment, the risk of stroke is not completely mitigated. The other aspect to think about is that not only can they form clots on the arterial side, which is where strokes can occur, but they can also develop venous clots. And that is something that left atrial appendage closure cannot fix. So if they develop venous clots in their legs or develop pulmonary embolism, that's a completely different situation, and they will need to be on systemic anticoagulation as a result. So that's some of the limitations that we have to keep in mind with regards to the utility of left atrial appendage closure in cancer patients.
Wow. Really, really complex intersection between these vulnerable patients and also rhythm strategy, especially atrial fibrillation, as we think about preventing strokes and how to best serve and take care of these patients. Dr. Tan, thank you for joining us. It was really interesting to see, the challenges that you're seeing with these cancer patients, the factors complicating risk assessment, this potential for left atrial appendage closure as maybe an alternative strategy, maybe in the right patient, as with most of our devices. Again, I hope you come back. We really appreciate having you, and continue to look forward to your work in the field. Thank you again for joining us.
Appreciate it. Thanks so much.
Thank you for joining us today. We invite you to share your thoughts and suggestions about the podcast at cveducation.mayo.edu. Be sure to subscribe to a Mayo Clinic Cardiovascular CME podcast on your favorite platform. And tune in every other week to explore today's most pressing electrocardiography topics with your colleagues at Mayo Clinic.
This has been a Mayo Clinic podcast.
At Mayo Clinic, learning fuels world-class care. I'm Dr. Peter Noseworthy, Chair of the Division of Cardiac Electrophysiology. I hope you enjoyed today's episode, and I want to let you know about the full courses that we have available. Head over to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses. Join the thousands of clinicians who have already turned their curiosity into expertise at cveducation.mayo.edu.